We're here today on a beautiful August day in 2019 with Dr. Alice Coombs, who is president of the Massachusetts Medical Society in 2010 and 2011. Welcome.
Thank you very much. So happy to be here.
Yeah, so let's get into it. What were the front burner issues back in 2010 when you were president?
Well, we were watching and witnessing the birthing of the Affordable Care Act, the ACA. And it was an incredible time because there were negotiations from every corner. Every stakeholder had a role to play in coming to the table to make a difference. And it was all about healthcare access, although there were a lot of other things included, but we wanted to cover the uninsured. We wanted to help the people who were underinsured, and we wanted to make a difference in terms of patients being able to see doctors in a timely fashion, and also to make a difference with those who had inadequate access, even though they were insured. Their ability to navigate the healthcare system needed to be addressed.
So this is interesting because you, here in Massachusetts, we already had a Health Care Act in place that was aimed at covering the people who had previously been uninsured. And the Affordable Care Act has pretty much been modeled with a few minor differences on the Massachusetts experience. Did you find yourself being called to discuss this outside of the state?
So it was a two-edged sword because because of the contention, many states felt that Massachusetts was a different type of state based on a number of socioeconomic issues. So whereas we could do a number of innovative things, such as alter the federal poverty level to tweak it to the point where we could get the 98.5% coverage, there were other states like Mississippi and Louisiana that had such low average income that their federal poverty their rate for adjusting up to where we were going to have an acceptable 138% of the federal poverty level to cover the people in their state. Right. Was going to be a higher lift for them. And so they were concerned about the immediate effects. What they were concerned about is when they would have to pay 10% of the cost of the coverage of the ones that qualified for the Affordable Care Act. So that made it very hard because people looked at Massachusetts as, some looked at it like they're the best thing since sliced bread. We ought to follow them. They're doing it right. That's what we need to have for patients. And there were patients from other states to say, why can't we do the same thing? On the other side of the pendulum, there were legislators, there were others who felt like we cannot be compared with Massachusetts.
Right.
They had the least amount of people being covered by insurance, being uninsured in the first place.
Right. We were under 10% at a time when the rest of the country was 15 plus.
Yes. So we were an outlier in that we were a good outlier, and that we covered more of the patients in our Commonwealth. So it was a two-edged sword. So when we would go places nationally and talk about the miracle of Massachusetts being that we could actually cover nearly a total population, it was a mixed bag because some would listen with anticipation of, oh, I want to go back and do something like this in my state. Others would look and they would be very critical because they would say it would never work. That blueprint and that template's not going to work in my state.
The policy has to match the population.
Yes.
So what other things were there? That is huge, but you must have had some other things as well.
There were a number of other issues that I felt that even with the Affordable Care Act, there were some major outliers, and some things such as the cost of drugs and the rate of rise of the increase in pricing of drugs and how that impaired patients' adherence. Patients would make decisions and continue to make decisions based on the cost sharing that they have to experience. And that influences how well your patient does in the big picture. If they're hypertensive and they don't take their hypertensive medication, they have a stroke, I mean, that's a major morbidity and increases the mortality. And so those are the things that we needed to address as well. We did in some fashion, but we never really accomplished some of the things that we wanted to do with controlling the escalating prices of drugs.
So this is interesting because initially when healthcare legislation was passed in Massachusetts around 2007, 2008, it addressed the access issue. And a few years later, when you were president, they were starting to confront the problems regarding cost. And so during your presidential year, you were involved with the state addressing the cost issue, and you were also involved with the federal government trying to pass the Affordable Care Act, which, although it had the word affordable in its title, really was an access program more than a cost program.
So it's very interesting that you should say that. The governor of Massachusetts was motivated by legislative mandate to create the Governor's Tab Commission on Payment Reform. And it was a wonderful opportunity for stakeholders to come together to see what we could do in the state of Massachusetts to curb the rate of rise of increased healthcare spending. And I think the positive thing was that we did this laudable act of covering patients, but the problem was we had the highest spend per capita for healthcare in the country.
Right.
And so we had a few records. We had some records that were very good, but we needed to control this cost conundrum that we were in. And so this Payment Reform Commission actually addressed so many issues. And looking back on it, I think it was a very good thing because it forced the medical society to come to the table with options and also to consider how do we navigate this space of we have to do something as physicians to help with the cost of healthcare. And so it meant for us at the Medical Society that we almost, it was like a campaign that we went to most of the hospital areas within the Commonwealth. We had a schedule. We had a toolkit. We actually went to hospitals, medical society meetings, and we would go there and talk about the pro cons of all the things that we were including. Out of that came some really interesting things. So I can honestly say that I'm happy to say that we were involved with the first part of malpractice reform in the state of Massachusetts, because the governor said, okay, the cost is going up. What else can we do to kind of curb the overall cost? Are there things that are not necessarily directly related to the spending of healthcare, the hospital bills, the pharma, that maybe it's on another level that interfaces with healthcare spending? And indeed it was. So we actually deliberated and we thought about defensive medicine. We thought about tort reform. We thought about litigation. And so we did a number of investigatory meetings. We talked about what was done in the University of Michigan with the early offer and apology. And so we came back to the governor and we said, hey, how about this? Can we have something inculcated within the body of this great effort, the action plan, that we have a plan where if there is an adverse event, that an entity, whether it's a physician group, whether it's a hospital, has an opportunity for 6 months to do an investigation and to look at what really happened with an adverse event. Because we're all about quality, we're all about good outcome and protecting the patient. And there would be more transparency with that because the patients wouldn't sue in that period, but they would allow the system to look with root cause analysis, and then they could have the opportunity to come back, dialogue with the patient or whoever the event happened with, and then they could actually have an opportunity to say, you know, we've reviewed this and we don't see that there was anything that we could have done differently. Or they would look at the incident or whether the event was, and they would say, these are the problems in our system that we have found, we have discovered this, and we want to make it right by you. They could then go to the families, the patients, and right the wrongs if they were due to a healthcare system error or fault or something that happened as a result of something not done according to the standard or some breach of duty. So those are the things that we actually were able to do with the payment reform. And Mass Medical Society, we worked overtime. And we actually did incredible things like we recruited people from different areas of the state to come along with us, to be a part of the message. And it was really a consensus building effort. And it wasn't 100% that everyone agreed with everything, but in the end, I think people, most folks, most of the physicians felt like this is something that's going to be for the good of the Commonwealth as a whole. And I can honestly say that at the beginning, we felt a lot of pushback. We felt a lot of concern because what was being proposed was global payment. And for them, it sounds just like managed care that happened in the 90s, where physicians were forced to go on a per member per month cost of patient kind of payment, and they didn't know the risk that was involved with their patients, the risk for high-cost patients, and they lost out in the end. And part of that had to do with they had no knowledge base of what their panels looked like. And they had no negotiating powers, and they didn't have the financial background to go up front and say, this is what I'm going to need. And the insurance companies, many of them probably were inadequate to assess what was really adequate and fair payment for physicians.
So you're pointing out a lot of things here. So getting right at the core of what the medical society does. Because on the one hand, part of your charge is to educate physicians so that they're aware of everything that's going on around them while they're practicing. And so you conducted the outreach with the help of the medical society. On the other hand, you're advocating for patients and for physicians with this huge healthcare system and all the places it touches. And there were probably, tell me about the number of people who are at the table, what kind of industries or the like.
So for the commission, we had several legislators from both the Senate, from the Senate Finance Committee. We had persons from the public health sector. We had the head of Blue Cross Blue Shield was there. And we had not just that insurer, but we had other people from the insurance agency. We had a number of economists or people who were professors at Harvard, working also as a part, not necessarily on the commission, but as a part of our reporting. And if we did any kind of studies, we had the head person who was actually directing how we go about doing each one of our deliberations, and each one of our sessions was held. So we would actually take each session and have many times a subsession that would actually be catered to informing us of what literature's out there and what information we could get. We had actual data on costs. We had actual data on the distribution of patients. So it was a robust data set that was collected for us so we could actually form correct conclusions. And I think that was very helpful.
This brings up a couple of things, which is at this point in time, when you're doing this, the healthcare is 18 or 20% of the economy in Massachusetts. And so the stakes are really high. A lot of different organizations have a piece of this and have a lot of interests in there. And this is not a negotiation or a discussion that you'd want to go into unarmed. And so the other part of this medical society function has to do with backing you up with the research and the
and the medical society was incredible. At the time, we had Frank Forden, Rick Gullah, and we would have prep sessions before we went in with all the data. It was absolutely incredible. And I think I would not have been successful without people like that, Alex Calcagno. I think that Linda Healy and all the entire team made it happen for me as an officer. Going before any of the state legislative meetings, I could actually present information. And they were interested in what does it look like for a practicing physician in terms of things like wait times, patient wait times. How is that influenced by, what we do on the payment side? Patient decision making. Another thing, Dale, I want to say that was really prevalent at the time was this whole issue of the sustainable growth rate. And so that was another thing that physicians were constantly afraid of. And it was a policy whereby it was designed to keep the rate of healthcare cost rise to a minimum level. And it was tied to the inflation rate. So what they wanted was, basically, this is what the government wanted us to try to stay within that 2% margin of what the rate of inflation was.
Right.
Well, needless to say, that was not happening for
Right.
many years. And so every year, when the cost of health care would rise out of proportion to that delta that they wanted us to keep it within, they would look at the budget from the preceding year and say, oh, that wasn't good, and try to assess that for years going forward. So that happened year after year after year, and it culminated in a very, very large deficit that we allegedly, it
Right.
was like a perceived amount of money that people thought the physicians owed back to the Medicare program, specifically the CMS. And that was addressed later with the Medicare Access and Ship Reauthorization
Right.
Act. But during that time, before we had a solution to the problem, the SGR, the Sustainable Growth Rate, was something that we really had to deal with.
And this stems from the fact that policy is sometimes made at the government level without being fully informed regarding the cause and effect of what is behind the inflation rate. And in this particular case, we have an inflation rate that in many ways is driven by increases in other industries due to greater productivity.
Right.
But yet physicians and healthcare providers are basically being asked not only to be judicious about their use of funds, but also to give patients the time they need.
Right.
And so while we can feel good about a farmer increasing his productivity by 100 times, we probably don't want to see doctors seeing 100 times more patients in a day.
Right.
And so that was kind of what was behind this uncoupling.
Yes, and there were these two, well, probably a multiplicity of beliefs, but there was this strong belief that fee-for-service is evil.
Mm-hmm.
And so there was this pull over here. We need to have what's called the accountable care organizations.
Sure.
That assumed responsibility for cost and quality, and in that they were able to control the costs from year to year. They were deemed to be more efficient. But what we since have learned is that not one size fits all.
Yeah.
And so that and we know this from the Medicare literature, is that in certain environments, in certain regions of the country, fee-for-service is actually more efficient than some of what we call the accountable care
organizations.
Yes, and
which come with layers of management,
right,
which add to their costs.
And the same thing for comparison of the fee-for-service and the Medicare Advantage.
Yeah, yeah.
So, so we've learned that in given communities, it may be that the fee-for-service model and finance model is a majority of the kind of payment in that community. It may be that it's really important for us to support the individuals in that community who have problems with transitioning to a more advanced healthcare delivery system. Some of them will move naturally to a what we call a more elite or more risk-bearing accountable care organization. And they will do that with time, but they will need support as that happens. And that's the story we learned over and over again back in 2010, 2011. Physicians need support.
Right.
You just can't go in with the carrots and sticks. And at that table, we heard carrots and sticks. And because of that, I felt like as a practicing physician, I could actually give examples where carrots and sticks don't matter as much as you relating to the physician and what their practice was actually going through.
Right.
So physicians were really kind of suffering and navigating this whole new system. And some feared that I need to have a new IT system, it's going to cost me overhead, and there were so many other challenges. So they didn't really have the infrastructure to go forward.
Physicians aren't really trained in assessing risk at that level. And I think that part of what you're saying is that when you were president, and even as we have this conversation today, the issue as to who takes responsibility for risk, how you assess risk, and the other contributor to cost is just assessing reasonable costs for services or products.
Right.
Those things are still being worked out, and we haven't found a solution to them yet.
And that whole subject of risk and risk adjustment is so important. It is the rate limiting step even now when you talk about accountable care organizations, because if risk adjustments are not done well, a physician gets penalized for taking care of sicker patients.
Exactly.
You know, because you're taking care of patients with comorbid conditions that may be 3 or 4, whereas someone who's practicing in a, say, a community that has healthier individuals will have less sick patients. And if you say that they're equivalent, then this physician who has to spend more time taking care, more time explaining, giving medications and explaining what the drugs are going to do, and emphasizing adherence. And also, the other piece of it is case support. When that patient leaves out, how does that patient get back to the hospital? How does that patient get back to the, how does the patient gets to the hospital to do the screening test? How does the patient get back to the office? And so there's this whole other issue about determinants of health, social determinants of health. And that becomes a major hurdle when we say you have people who have social determinants of health that actually hamper their ability to navigate the system, to do what's necessary to have a better outcome, and then you have patients who don't.
Right. And at this point in time, this is a very important point you bring up, we're in a situation where the healthcare system in many ways is putting out fires that started in society, that started in a community, that were public health issues. And so as that umbrella gets bigger and bigger, as we take on more of these problems, the costs go up.
Right.
And perhaps, as you bring up, the solutions reside elsewhere, possibly in public health, possibly in education or other areas.
And that's our greatest challenge. It is absolutely our greatest challenge, is you cannot separate food deserts, rat infestation, and some of the things with housing and transportation from healthcare.
Right.
And so as much as we want to do it every time, I mean, this is studies that were done in Boston City that showed that rodent infestation actually had a lot to do with asthma exacerbations in children.
Sure.
So there were all these things, information that we had at our fingertips right there as we deliberated. So everyone understands that social determinants of health influences healthcare outcomes. Who has the boldness to say, let's actually do something about it?
Right.
Even today, I argue that how do you put the risk adjustment into, how do you put the social determinants of healthcare into risk adjustment and level the playing field?
Right.
How do we level the playing field from providers who are taking care of very sick patients, who have so many problems and challenges with socioeconomic status, and differentiating that provider is doing something that they need to be encouraged to do. They're the missionaries of medicine.
Right.
And we ought to encourage them.